Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today, my guest is actually a fan of PEM Rules who's been listening for quite a while and actually has quite a few rules of his own. Today, I wanted to talk to Dr. Rammy Assaf, who actually has quite a lot of rules of his own. He's been listening to the show for a long time and contacted me through the website with the rules that he has. I thought we can all listen to Dr. Assaf and learn from his wisdom. So, welcome, Rammy, to PEM Rules. I appreciate your time. I always appreciate my guests' time coming on the show because I know you guys are busy. And specifically, Rammy, I want to thank you because you approached me via the website. And I can't tell you how much I appreciate people who listen to PEM Rules. You gave me a lot of compliments. I really, really appreciate it. I'm really glad that PEM Rule has been helping you. I hope it's been helping you a lot as an attending. Let me just introduce you to the listeners. So, Rammy, and please correct me if I'm wrong at any point, you are originally from LA. You completed your medical school at the University of Miami, followed by pediatric residency, just like me, in Children's Hospital of LA and fellowship at UCLA Harbor Medical Center. Currently, Rammy, you are a PEM attending in Southern California, and you've been attending for how long?
About a year and a half.
Oh, wow. So fresh. And I know, Rammy, that in addition to your full-time clinical work, you also do quite a lot of research. Currently, you are the PI on 4 research projects. And as a fellow, you have published over 20 publications as a first author. Is that right?
Through from residency, fellowship, and through where I am currently. That's right.
That's very, very impressive. That's very impressive at your young age. So welcome, Rammy, to the show. How are you?
It's great. It's such an honor to be here. I'm a huge fan of the show, and I'm just so happy we can be here.
That's great. And the honor is all mine. And let me start, Rammy, with the first question that I'm sure you know, because everybody gets the same first question. Young attending, what's your definition of a good PEM attending? One who does what?
In my opinion, I would say it's someone who's really a team player at the core, someone who's versatile, a master of their craft. But at the end of the day, someone who's humble. We know that the breadth of medical literature is so wide and ever-changing, and especially in a broad specialty like emergency medicine, one can never be on top of the newest and latest of every other field out there. One can, however, dedicate themselves to continually being better, being open to learn, not just in the form of CMEs, but from one's patients, families, colleagues, and diverse workforce. And the emergency department is a unique place full of contrasts in which day in and day out, a provider must really have the finesse to keep the department moving while giving each family the precious time and space they really need. And that, I think, is the art of emergency medicine at the end of the day.
That's very well said. And I could not agree more. You basically alluded to one of my rules, be a PGY forever. That's my email signature also. Once a doctor, always a learner and a teacher. So I completely agree. The CME we do is a little drop in the bucket. There's so much more to learn. So thank you very much for that. As a fan of PEM Rules, and again, I'm super humbled and complimented and really appreciate the good words. If you know the show, I'd love to ask you, what is your favorite PEM rule and why?
Well, I would say it's really hard to narrow down, but lately it's been worried parents don't go home. And it's true, if we fail to reassure parents that their child likely will return to the emergency department or go somewhere else, and potentially with new or progressed symptoms. In a busy emergency department, trying to meet the concerns of parents, I've actually heard others label what we do as quote unquote customer service. But I think it's so much more nuanced. Having a trained set of eyes and ears and hands to pick up the red flags on history and exam, to meaningfully take the time to listen and prioritize a parent's biggest concerns, and to have the experienced foresight to guide the family through a workup, making decisions on what's most likely to help that patient and potentially what could cause them harm.
Yeah, that's again very well said. I couldn't agree more. easier said than done, as we all know, but those are excellent qualities that are super important for any PEM clinician attending NPPA nurse. I couldn't agree more. And the next question I have, Rami, really, really impressive. You actually, when you contacted me, you sent me a list of rules or pearls, I call them PEM rules, that you have. And I got to be honest, you had so many. You can probably start PEM Rules 2.0. It was quite a long list and really really good stuff. So I'd love to know your favorite rules, where you learned them. By all means, if you learned them from someone else, give them the credit. And what do they mean to you? The stage is yours.
Thank you. I divided these up in a similar way that you had already had organized. So let's start with approach. Learn when to switch from system one thinking or pattern recognition to system two or deliberate slow thinking. And of course, these are not my terms. These specific terms here are credited to the writings of the great Dr. Daniel Kahneman. So intentional system switching, I think, can be done by using cognitive checkpoints, especially among medically complex patients. Also, if you have a patient with an atypical presentation, and or when you're on the fence about your disposition. The checkpoints, I think, are really just about asking yourself a series of questions. For example, ask, who is this patient? What's going on? What if your assumptions about the patient are wrong? What is the worst case scenario? And where is the best place for this patient? For example, wards, ICU. And something that I've really picked on over the last kind of couple months, I would say especially be aware of cognitive bias during the last hour of your shift when fatigue is at its worst. When your body and brain are fatigued, the brain wants to take shortcuts. So I think being aware of that is very important. So a good example of all this is a well-appearing child with a prolonged fever. Ask yourself, is the patient truly immunocompetent? How many days has this patient truly been febrile? And in what pattern? What exposures do they have? If there's any prior workup, what is the certainty of that workup? Were there any assumptions, for example, for diagnostic momentum? What if the patient decompensates? And lastly, keep in mind that when a nurse brings up a concern to you and or they themselves say they're worried, what they're really asking for most of the time is to go and see that patient bedside.
Yes, those are all really, really good points, especially the last one, especially as an attending. They're basically asking for you to come and going to see the patient at the bedside when the nurse is asking you goes a very, very long way. So that's a great rule. Learn when to switch from system one thinking, pattern recognition, to system two, deliberate slow thinking. I love that. Again, like you said, easier said than done, especially towards the end of a 10 or 12-hour shifts. Completely agree. What else do you have for us, Rami?
So the second group is around communication. So patient families that you quote unquote like the least, for example, the quote unquote difficult patient or difficult family, those are the ones that require the most thoughtful approach. You never want to leave your shift with a parent upset with your plan. You want to always go back in, talk with the parents, and observe and examine that child again, especially noting the interaction they have with their parent. If the parent is saying that their child is lethargic, they're saying it for a reason. Get comfortable applying tickles in your observation. Tickles stands for tone, interaction, consolability, look, and speech/cry. For example, is that infant holding their head up well, or are they hypotonic? Are they having what would be expected an age-appropriate interaction with their family, with their parent? Are they consolable as they're crying? Fussy but consolable is okay, but fussy non-consolable is not. Do they have a particular look in their eyes? Are they glossy-eyed, or are they looking about the room curiously? What is the quality of their speech? Is it muffled? Is it shrill? Is it high-pitched? So really, All parents want is to be heard. One never should discredit them. Ask the parent about what they are most worried about and put together a plan that is reasonable. Another rule, I think, with parents would be parents are allowed to have their doubts, but they can't be dangerous. So this is actually adapted from what I learned in fellowship under Dr. Tim Horechko. So as an example, in many cases, one cannot force a parent into obtaining an LP for their child. However, if a parent blocks a CT scan in a patient that you think may have an intracranial bleed, it's time to call backup.
I couldn't agree more. Again, Rami, excellent rules. And I got to tell you, especially the first rule you said about patient families you like the least, the difficult quote unquote patients are the ones you should spend the most time with. I couldn't agree more. And actually, Dr. Rick Saladino, who was my attending in fellowship and is the inspiration behind my podcast, used to say that to us fellows all the time. Sometimes you start your shift and the sign out goes something like, the parents in room 5 are crazy, don't go there. That's the room you want to be at the most. They're not crazy, they're just worried. And that means you, as the attending, have some more work to do there. So I couldn't agree more. Those are great rules. What about some rules in critical care? You have some more of those, right?
I do. I'm passionate about airway. So this next rule in critical care is goes like this. The biggest error in airway management is failing to prepare for failure. What you'll hear experienced individuals say is if something doesn't work, next time try it in a different way. However, you want to have a plan to follow when in crisis with a crashing patient. Have an approach in which you might switch up laryngoscopy tools if needed. Think of resuscitative sequence intubation rather than rapid sequence intubation, and address physiologic derangements before intubation. For example, you want to optimize hemodynamics and oxygenation, of course, prior to intubation. If you're intubating a patient in status epilepticus, it's a good idea to have an NS bolus hung and a push dose epi bedside in case that patient's hemodynamics need to be optimized. And remember, sedation meds can tip a patient's hemodynamics over. You want to exercise your airway management mind by mentally running through what size airway tools you might use on your routine stable patients that you see throughout the day. A good pediatric rule of thumb I learned from Dr. Marianne Gauch-Hill is 1-5-10, 4-5-6. A 1-year-old will need a 4-0 cuff tube, a 5-year-old a 5-0 cuff tube, and a 10-year-old a 6-0 cuff tube. And of course, you always want to have a half size smaller available.
Yeah, excellent. So kind of similar to, it's very interesting. Your rules, very similar to PEM rules. The ones that I learned is, and I think I spoke about it in one of the episodes, is to figure out the size of the tube I need. I have memorized from one of my attendings, 4 if you're 1, 5 if you're 4, 6 if you're 8. And kind of similar to yours, I do not do math under pressure. I don't think that works very well for the majority of us. So 4 if you're 1-year-old, 5 if you're 4-year-old, 6 if you're 8-year-old, kind of similar along the way that Marianne Gaucher-Hill taught you. And I know her, she's an excellent physician. And with regards to your other rule, the biggest error in airway management is failing to prepare to failure. Again, perfect rule. I couldn't agree more. I kind of use a good ER doctor is always ready, be a step ahead. It's kind of along the same way, preparing for failure. And especially with airway and especially with children, that goes a very long way and can be very crucial. So those are excellent. Lastly, Rami, I know that like me, you're very passionate about teaching. You work with a lot of learners and you have a rule about learners. Is that right?
That's right. And this one I love because it's so simple, but there's a lot behind it. And that's with learners, clear as kind. We can't hold our learners to a standard that we don't inform them of beforehand. Tell your team in the emergency department, we expect short HPIs and to the point exams, assessments, and plans. To help learners organize their differential diagnosis, ask them to use SPIT, SPIT. What's most serious? what's most probable diagnosis and what's most interesting diagnosis. And what is the treatment you want to go with? And by the way, that's from Dr. Diane Birnbaumer, Emeritus Professor of Medicine at UCLA. Have a humble intro with new learners and ask, what is it that you're working on? And how can I help you get to where you want to be? It's all about facilitating psychological safety for our team members and establishing an appropriate work culture and having a perspective with appreciation for others at the core.
Yeah, so I gotta say again, this reminds me of my rule that I actually never thought about using with the trainees. I use it for parents and patients. I call it set up the expectations. So the classic example when the parents come in with a 16-year-old daughter who has abdominal pain and they're very worried, I say something to the extent, Mom and Dad, I'm glad you came. We're gonna look into this. Just so you're aware, figuring out belly pain in a girl may take a while. You're going to be here for a few hours. So setting up the expectations. But I got to be honest, I never thought about doing that with my trainees. I think it's a great idea to sit with them at the first shift, beginning of the shift. What can we work with you on? What do you want to learn, etc. It's specifically a good idea for us who work with family medicine residents and pediatric residents and PEM fellows because everybody has their own kind of point of view and need to learn different things from different perspectives. So I think that's great. The other thing that I kind of similar along your line is I talk to the residents about every patient needs an assessment and needs a plan. So I think especially with medical students, they're very good about presenting the information they received. But what are we going to do with that information? So every patient deserves an assessment and deserve a plan, and it can be Tylenol and discharge because I think the child is virulentless and that's it. But you have to have an assessment. You have to have a plan. So again, I couldn't agree more. Rami, I couldn't thank you enough for coming on the show. And thank you so much for all the compliments and being a fan of PEM Rules. I was even more excited to learn that you like System of a Down, which is a great band, and you wanted me to play anything by System of a Down. So that's a great challenge. And you mentioned that they're actually from your hometown?
I'm from their hometown. I guess it's no way
sure. Well, depends how you look at it.
Yeah, I'm from Glendale, California, so or a very small town next to it, but they're basically sister towns. So
fantastic. So my favorite System of a Down song, as you probably can imagine, is I'm not even sure how to pronounce this. Is it Chop Suey? Is that how you pronounce it?
Chop Suey, that's right.
Chop Suey, and a great song. It sounds very difficult, but I actually looked into it. It's actually not that challenging. I think I can do it. Maybe the drumming will be a bit of a challenge, but I'm going to have GarageBand work on that part. So again, thank you very much. Thanks for all those rules. Really, really great wisdom. And I hope we can do this again sometime. You have a very, very long list. I think PEM Rules listeners can learn more from you.
This was such an honor. Thank you so much, Yaron, for hosting me. And yeah, hope to see you again in the future.
Thank you very much. And that is it for today, guys. Thank you very much for listening to PEM Rules. And thank you, Rami, for coming on the show. Really great advice and great wisdom. I most certainly plan to bring Rami again on the show so he can share more of his rules with us. He has quite a long list, as I mentioned. Again, thank you for listening to the show and thank you for writing to me. If, like Rami, you want to come on the show because you have something that we, physicians, clinicians, can learn from, by all means, just contact me through the website and I'd love to have you on the show. Check out pemrules.com and check out my EP monthly articles. Again, thanks again. I hope you like System of a Down. I can only play the beginning of the song, which is actually the best part. Hope you enjoy it. Thanks very much.